So good evening, everyone, and welcome on behalf of BOMSS to another journal club. And before we get started, I'll just announce for you to know that the next educational session is on Wednesday, the 27th of July at 8 p.m. And Torsten Albers is going to be giving some education on the complications of JJ anastomoses for those who still do them. So please do register and attend that Wednesday, the 27th of July at 8 p.m. So there's a little change in the schedule tonight. No doubt, like in your own hospitals, COVID seems to be wiping out many people in BOMSS and half of the presenters this evening. So we're just presenting one paper tonight, so we're likely to finish up a bit early. During the talk and the presentation, a reminder please to put all your questions as you think of them in the chat so we can come back to them and talk them through at the end. So tonight is supported by Apollo, and we have Imperial College presenting for us. And the paper being presented is by Dr. Shwan Karim, who's a consultant gastroenterologist and interventional endoscopist at the Hammersmith. Who did some training out in New Zealand and then a fellowship in Australia, and has been at Imperial for some 3 years. And we all know Imperial does a lot of good bariatric work and tertiary referral work. So without further ado, I'll introduce you over to Dr. Shwan Karim.
Thank you very much, Nick, and thank you everyone for having me here today. I'll just share my slides with you in a second. So thank you for having me tonight in this journal club. And as Nick said, our expectation was to have 3 of us presenting today, but unfortunately 2 of us are down, so you're left with just Robin presenting tonight. Nonetheless, what we will do is we'll take this paper from gastrointestinal endoscopy, which was published in November last year. GIE, you guys are probably familiar with this, has an impact factor of 10.396. And this paper looks into endoscopic versus surgical gastrojejunal revision for weight regain in Roux-en-Y gastric bypass patients. So this is a 5-year safety and efficacy comparison. And this is through a large 2 tertiary centers in Boston in the States. So the paper starts with an introduction and confirms the role of Roux-en-Y in gastric bypass as a commonest bariatric surgery performed worldwide. And as we all know, it is very effective in reversing components of the metabolic syndrome. This is through the significant 25 to 30% total weight loss and the excess weight loss of up to 68% in this modality. Nonetheless, weight regain is common, and nearly a third of individuals regain their entire pre-bypass weight. And there's so many reasons for that, including behavioral, psychosocial, and medical. But one important factor is actually anatomical factors that contribute to regain of weight. And one of the most important factors anatomically is the gastrojejunal anastomosis incompetence or dilatation. So kind of becomes wider and allows the regain. This is in particular true when it is more than 15 millimeter in diameter. So we know in general, we aim for somewhere below 10 millimeters when these anastomoses are done, because we know from studies that this is associated with more weight loss. But this is when they go above 15 millimeter, this is in particular important when it comes to regain. So 8% of regain of the maximum weight loss for every 10 millimeter dilatation is noted at 5 years in some studies. So repair of such anatomical change can be done either surgically or endoscopically. Historically, surgical approach was the mainstay, but over the last while, endoscopic approach has become widely available. So when we look at the anastomosis, the two approaches is the surgical revision, which obviously you guys don't need me to tell you about that, but it is done either laparoscopic or with open laparotomy. And you either do oversew or you resect, then you oversew with shortening of the gastric remnant. The alternative to that is the endoscopic approach, where with an endoscope you go into the anastomosis, and first you treat the anastomosis with coagulation therapy, which is usually used with APC, so argon plasma coagulation. And that basically allows for fibrosis, but also during the procedure allows for the stitches to kind of stay in place and gives it more give. And then what we do is we do an over the scope platform, an overstitch, and what we use is the Apollo device. The Apollo overstitch, which is over the scope, allows us to do either interrupted stitching or continuous stitching to reduce the outlet. And that's the definition of an outlet reduction endoscopically. Historically, the Apollo device needed a dual channel scope, but the newer generations, you can put it on any gastroscope. You just need a single lumen or single channel, really. So become much easier and much more available. So TOR is the transoral outlet reduction, or the endoscopic approach, and it's an endoscopic approach of the jejunal anastomotic repair. And you can use either purse string suturing or interrupted suturing. Although some studies show that purse string suturing comes with better outcomes in 1 year. Overall, it's a very safe approach, but comes with about 5 to 11.4% adverse events. This in comparison to surgical approaches, which in literature reported about 8 to 50% adverse events. So this paper set out to kind of ask a question: when we put those two approaches together, how do they compare? And their primary aim was to compare the safety of the endoscopic approach versus the surgical repair. And they divided that to early adverse events versus late. And then they looked into the second question, which is to evaluate efficacy of the two approaches, inducing weight loss. And that was measured with absolute weight loss, the BMI, the percentage of the total weight loss, and the percentage of the excess weight loss at 1, 3, and 5 years. So the good thing about this is from the get-go is that you've got a good 5 years follow-up data for this paper. So how did they go about doing it? This was a retrospective matched cohort study in 2 tertiary referral centers in Boston. And they had follow-up for 5 years from an index date of gastrojejunal anastomotic revision or anastomosis revision. It was 1-to-1 matching of the endoscopic approach versus the surgical approach. All these cases, when matched, were within 7 years in age, and their BMIs were within 5, and their percentage of total weight loss between the surgery or between their bypass and the nadir weight was within 10%. And their weight regain was within 5%. So in general, they tried to match them very well. The patient characteristics were recorded, and we will look into that in a minute. And whether trainees were involved in the cases were recorded as well. Although I didn't see anything in the outcomes to highlight about training or so on. Anyone over 18 years of age was included, and they would have to be post-bypass regain of weight, at least to be partially attributed to incompetent anastomotic or gastrojejunal anastomosis, or a dilated gastrojejunal anastomosis. And those who would have gone under endoscopic or surgical revision. In their institution, patients eligible for bypass revision they will be eligible if they regained 15% or more of their initial maximum weight loss, and they should have been at least 2 years post-operative. So if we go to the results straight out, we'll talk about the baseline characteristics. So they had a total of 62 patients, and half and half, so 31 in the endoscopic and 31 in the surgical group. And as you can see, their age and their gender were relatively equal. And with regards to the total weight loss between surgery and the NADR percentage were equal as well. Weight regain from the initial post-bypass loss was pretty much similar as well. And you can see when they went to any intervention, their weight pre-revision was pretty much similar and statistically not significant, and their body mass index were similar as well. And the only thing that I could pick up on was the time since their bypass in those who had endoscopic approach were about, on average, 3 years post-operative. And that was the only thing that statistically was different between those two groups. But in general, it looks like they were well matched on both sides. And then they set out to answer the primary outcome, which was about the safety of this procedure. And as you can see, in general, the adverse events were more common in the surgical group, about 9 compared to 2 in the endoscopic group, and this was statistically significant. The complications recorded were GI leak or perforation, followed by ulceration, gastrojejunal anastomosis, stenosis, then GI bleeding or small bowel obstruction, and incarcerated incisional hernia. And overall, the serious adverse events were only recorded in the surgical group, whereas nothing happened or no serious adverse events occurred in the endoscopy group. And those were basically defined by those who had perforation, ulceration or marginal ulceration, small bowel obstruction, and an incarcerated incisional hernia. And overall, the early adverse events were more common in the surgical group, although that wasn't per se statistically significant. But you can see the serious adverse events were, again, statistically significant in these cohorts. And to answer the second question, which is regarding the efficacy, these two graphs look into the weight over 5 years follow-up with regards to time since revision, so post-revision at 1 year, 3 years, and 5 years. And overall, this looked quite similar. You can argue some of the surgical data look a bit better at the 1 year, and at the 3rd year they meet together. But overall, none of the measured outcomes, which were the total weight loss, the percentage of the total weight loss, and the percentage of the excess weight loss, were statistically significant. And the same thing goes on on this graph as we spoke about the total weight loss and the excess weight loss. So if we look at the basically at 1 year, for example, the weight was similar at 94 and 96, and the BMI was 34 versus 35, whereas the absolute weight loss was 10 kilograms versus 17 kilograms at 1 year for the surgical group, but this still wasn't statistically significant. And the percentage total weight loss was 9.7 versus 14%. And the excess weight loss was 13% versus 18.6%. And none of those were, their p-values were all 0.2 and 0.25 respectively. So really similar outcomes in general on both groups when it comes to efficacy. So the authors' initial conclusions were that gastrojejunal anastomosis incompetence is a common cause for weight regain, and that's true. The present study was actually important because it addressed a very important question, is the endoscopic versus surgical approach. And in this present study, they showed less adverse events with endoscopic route. There were no observed severe adverse events in the endoscopic group, and they highlighted that. And if they were to happen, if they've had adverse events in the endoscopic group, they would have been less protracted course and would have occurred earlier. And the other highlighted outcome was the similar weight loss at the end of the 5 years follow-up, really. So these were important factors for them. There are clearly some limitations that they reported on. And the first one is, and the obvious one, is the retrospective comparison, and that comes with its limitation. But there's obviously patient selection, maybe at least partially subject to confounding by the indication. And as you know, with comorbidities, it will dictate which choice of approach you will have. So you think about someone who's got multiple comorbidities, you probably would have gone to the endoscopic group. As with all these kind of studies, they always mention the limitation of these are all in experienced tertiary centers. I mean, in fact, these two centers basically produce almost all the data when it comes to endoscopic approach for bariatric surgery. All right, so Chris Thompson and their teams are just pretty much machines when it comes to that. So these are important things to remember. These are really experienced centers that perform these procedures. The last thing they mentioned is that minority of the surgical cases had the diameter of the gastrojejunal anastomosis measured before the intervention, and they therefore couldn't use this parameter as a way of comparing the two outcomes. So it would be interesting to see, well, endoscopically, we thought this is the diameter, surgically, we thought this is the diameter, and you can perhaps look at the outcomes, but they couldn't do this in this study because they didn't have the data. There are clearly strengths to this study, and I think this is a good study because of the direct comparison between two desired techniques. So finally, they've kind of addressed this question that we all have. They say it's a large number cases. I suppose it is a large number compared to other publications. It was a total of 62 patients. But the impressive thing is that you've got 5 years of follow-up, and that's really good value, I think. And the takeout, basically the take-home message was that endoscopic revision of gastrojejunal anastomosis has an improved safety profile, fewer total and serious adverse event, and yet provides similar long-term weight loss. So I think that's a reasonable conclusion as such. From my perspective, when I was thinking about this, and some of this is really stolen personal thoughts, because the paper comes with a really nice editorial at the GIE. I don't know if you guys have access to that, but the editorial gives us a bit of insight as well, and some of it is my thoughts as well. To me, actually, the third point here is key. I think this is totally an MDT approach, and MDT approach is key when it comes to this. There's no one size fits all as such, and it has to be a conversation between surgical, medical, allied health, psychologies, really a discussion that goes through MDT that chooses the right approach. You have to remember, bariatric surgery is highly effective in achieving weight loss. We already have the data, we already have the proof that this results in improvement and resolution of related comorbidities, okay? The most important thing to remember, however, is that weight regain is inevitable. It's gonna happen. And you have to think about this as a chronic disease rather than a one-stop shop. This is a chronic disease. patients go through multiple things when they present to us. This is the reason they regain their weight is complex. It's not a simple thing. It could be neurohormonal, physiological, and as we said, anatomical. And this paper really sheds light on one aspect of that. And that's why I think MDT approach is key when we make such decision. But in those who have dilated gastrojejunal anastomosis, I think we have enough data now to think that endoscopic approach is probably should be considered first. This is less invasive. It can be just done as a day case, and it reasonably has similar outcomes. And possibly with all that in mind, is perhaps more cost effective. But that's a question that there's no studies that I can think of that have looked into that. But those were my personal thoughts to add to what you guys think about and something to debate about. Now, when we compare that to our data, so Dr. Bansi with our bariatric surgery colleagues published their data from 2017 to 2018, and we had 23 patients. I think this is the largest UK series for gastrojejunal anastomosis revision, or so I'm told. The mean weight loss at early follow-up, so just about 3 months, was 6.7%, and the mean weight loss at 1 year was about 10%. So reasonably similar outcomes to international data. And we recorded no procedure-related complications. So this is just a bit more local data compared to what we read about usually. And just to add another kind of couple of slides, I just added these in the last minute because I know you guys were cut short by the presentations. Another approach to endoscopic revision is to use plication devices. We don't tend to use those at the moment. We tend to use the Apollo overstitch because it's easy and we use it often. But a plication device looks at the same way. So it's kind of full thickness suturing, but more like plication, I suppose, with tissue anchors, okay? And in fact, GIE, they just published this month a paper on this. So this is just on the July edition of the GIE from the same group from Boston. They looked into basically coagulation therapy of the anastomosis, followed by plication of the mucosa around the anastomosis to make it smaller. And that's all done over kind of an overtube. So you kind of make it into 10 millimeter or less. And what they showed at the 12 months, patient experienced about 9.5% total weight loss, and the clinical success rate was about 73%. The technical success rate was 100%, so it's an easy kind of procedure to do for them at least. And the total number of plication per case was 7 plications, so circumferentially around the anastomosis. There were about 12.6% adverse event rates, and stenosis was in about 10%, melena due to marginal ulceration, and deep vein thrombosis in about 1%. So this is just, I thought I'll add it on just as another approach endoscopically. I am clearly biased since I'm a gastroenterologist, so I just thought about putting this up as well. So I'll finish up with that. And we should have a nice discussion or a Q&A as you guys wish. Thank you very much.
Thank you very much, Dr. Karim. That was a brilliant presentation and really comprehensive. And thank you as a gastroenterologist for joining our surgical journal club. It's wonderful to have that interface between specialties, especially for a procedure that really does cross over between the two specialties. We've got a few questions already from our audience, and then perhaps we can go, there's some questions and comments from fellow members in the panel. But I think the first one that we had really was, A question from Dr. Hughes saying, how widely available is the endoscopic procedure in the UK?
Not so widely, mainly on the tertiary centers, I suppose, but it is slowly, I think, extending. We, in London, I know we do it in Imperial. I know Nick told us about Portsmouth, but it's mainly in the tertiary centers. There are a few centers only at the moment, but I think it's slowly spreading.
Okay, it's good. It's
so clearly, it is still few centers. You're right, not widely available, but slowly spreading, definitely.
Thank you. And then in the presentation about the paper, you mentioned that between the two groups, between the surgical and the endoscopic repair group, there was a difference in the time since their gastric bypass, the difference of 3 years. Do you have any thoughts onto why this is, and whether, and then my follow-up question to that is it patient selection, and who is the ideal patient for the endoscopic procedure? Is that the reason?
Yeah, you're right. I picked up on that, and there was nothing mentioned as such about it in the paper. I think you're right. At the end of the day, it goes back to what I was saying, that this is really an MDT approach, where you as a surgeon with the gastroenterologist, with the endocrinologist, with the psychologist and the dietitian, and make the right decision for the right patients. So for those who are perhaps very comorbid, there might have been delays in offering them an intervention, and then this becomes available, and then they can have this new intervention, perhaps, which they might be more suitable for if they have significant comorbidities. So I suspect that's probably the main reason behind it, to be honest.
Mm-hmm. Brilliant, thank you. And then we've got one more question from the audience here. Are there any clinical factors that might indicate that a GJ anastomosis revision might be required? And this is from Dr. Carly Hughes, says, I'm a GP, and since patients discharged after 2 years to the GP, is there anything from the history that the GP could detect at review, or should all patients with weight regain be referred back to the surgical centre for assessment?
That's a very good question, really. I mean, the main thing is to remember with the outlet being dilated, weight gain is one of the weight regain is one of the symptoms, but patients can also develop more symptoms such as dumping syndrome, and they can develop the symptoms associated with that, whether it is basically hypoglycemia, bloating. They could have just generally being unwell postprandially. So a lot of these things should be kept in mind as well. So you're absolutely right. Weight regain is one part of those patients, but other things to look out for would be symptoms like that, such as dumping syndrome.
Okay, then perhaps Mr. Carter, in terms of like the refer back for weight regain from the GP, I don't know if you want to elaborate from a surgical perspective, what we would hope.
I think we're all well aware of the current, well, we have guidance about we can only offer revisional surgery to those who have ongoing comorbidities associated with their obesity, rather than just weight regain per se. So that depends on how one interprets that in one's own area. But yes, thank you, Firas. But just to promote debate, if you, Sean, if you have someone in your MDT who has weight regain and diabetes ongoing and sleep apnea, and they have a large pouch and a large dilated GJ, would you consider taking those on, or would you refer to your surgeon?
Yeah, that's a very good question. I mean, that's a balance between what you're trying to say is the comorbidities versus having a big pouch as well that might need reduction, isn't it? But I think in those persons who are really comorbid with higher risk of surgery, I think it is worth to go with endoscopic intervention in those cases and see their outcome thereafter. I think, again, what we're seeing from the data is that the results can be satisfactory and the adverse events might be less. So it could be a good first step towards managing these patients.
That's great. Yeah, thank you. And you know, the last slide you showed, your 23 patients with 10% a year, a 10% total body weight loss is very commendable indeed. Are you finding that your MDT is sending more and more patients to you rather than for surgical revision because the results speak for themselves?
We work pretty much very closely with, as you probably have as well, it's a weekly MDT meeting. Patients get referred as needed. We do have more referrals, but the problem has been, as for you as well, over the last 2 years, things have stopped completely. And now we're kind of trying to go back to things happening again. But overall, the shift is going towards that. You're right.
So we have a question in the Q&A from Nihal. What is your optimal diameter of GJA that you go for when you're revising someone? And can you tell me roughly how long the procedure takes now you've got experience in your unit?
Yeah, good on you. It's so what we look for is 10 millimeters and less. So you can put an over tube on around through the anastomosis and then do the revision. Or nowadays, what we do is we just do it with vision and estimate of that. But basically, we aim for less than 10 millimeter. And overall, with experience now, the timing of the procedure, probably about 40 minutes to 45 minutes, what we do.
That's probably quite a bit quicker than surgical time. Firas, we had a question about that as well in the box there. Who should be doing these endoscopic revisions? Do you think there's a role for surgeons, bariatric surgeons, to take this on as well?
Yes, I suppose what we want to highlight is that the people who are involved with these patients. So we have surgical colleagues who do endoscopy and who take over the care of these patients. So yes, as long as you've got the training and you've got the ability to do the procedures and deal with their complications. In general, what we see in this day and time is that at tertiary centers, we're going towards endoscopy done by gastroenterology colleagues working with besides surgical colleagues. And I think that's probably the way things have been moving as such. But yeah, as long there's no contraindication as such to who does this procedure, as long as they've got the competency and they've trained and become able to perform, but also to deal with the complications associated with such procedures.
Dr. Green, could I just ask you about training, because as you're mentioning, so for the surgical trainees and perhaps the gastroenterology trainees who are coming through want to learn how to do this. At the point of, if we say that the standard is reaching the basic competencies and getting the JAG sign-off for endoscopy, how long or what is the learning curve that you envisage in terms of them being able to then learn procedures like this? Should be something that we factor in earlier into training.
Yeah, very, very good question. From the point of getting competencies, to me is very, very kind of a vague area, because if you do 200 and then you're signed off, that's to me is basics endoscopy. And I think in general, once you've done that and you are confident with dealing with some acute endoscopy and you're having experience with some therapeutic endoscopy, then there is no reason why you can't expand your basically skills. And what we would do is, first, I would do a course in overstitch and how to do it in ex vivo. And then I would usually, what I've done is, I've done it on pig tissue. And then I've seen heaps of endoscopic procedures done by mentors first. Before I did simple cases, which was in the form of actually stitching a stent in place, for example, which is much easier than doing a revision, for example. And once I was happy to do that, then I kind of progressed with stitching. So that kind of takes a bit of time. It takes a bit of commitment, but it is very doable. Now, the good thing is, I mean, for us, and Rory is writing there as well, is that their support from the industry was there as well. So for us, we use the Apollo Overstitch, which is actually the only device, but they're very helpful. And with every cases I've done, they would have been there. So that's really good because they've got experience as well. So that will be the next stage once you've done them. So overall, I think it takes basic training is good in endoscopy, of course, you have that, but you can't jump into overstitch immediately after that. I think people should have a bit of therapeutic skills built up, followed by training ex vivo, look at cases through with experts, and even online, look at videos, how they've done. There's heaps of literature and heaps of videos online to look at these things, and then observe and then be proctored as such.
That's great. Thanks so much, Juan. And just refer those of you who haven't noticed that Rory's posted some very useful links to a decent paper and review on dumping and endoscopic revision, and reminds us all that those who are interested in endoscopic training, Apollo are obviously very keen to support and help develop people to push the endo stitch. So I think in the absence of any further questions, we'll bring this session to a close. So thank you very much, Dr. Karim, for a very elegant presentation discussion afterwards. You may find you have a flurry of referrals from around the country coming to you now.
Lovely, thank you.
And to the rest of you, and to you as well, Shwan, don't forget Wednesday the 27th of July for the next education session with Torsten Albers, who many of us know very well. So I wish you all a good night and thank you very much for attending. Remind your friends that obviously this is for those who registered and make it, that this will be up on YouTube in the standard fashion, as will all the other journal clubs. So thank you everyone. Roxana, Rory and Matt, thank you.
Thank you so much everyone. Thanks for having me. Cheers.
Thank you all. Good night.
Yeah.
Night everyone.
All right.